As in our previous lecture on the medulla, our discussion on the pons will focus on the clinical relevance of the neuroanatomy. And so there are several things in the pons here that are distinctive. One of them is that we're going to talk about a relationship between these two cranial nerves. In red here we have the sixth nerve abducens, and here is the facial nerve. And so we'll make a big deal of this, but notice how the facial nerve does something very unusual. It loops all the way back around the sixth nerve on its way out. And so we'll talk about a syndrome that occurs with a lesion here that involves a sixth and a seventh nerve palsy. Remember from last time we talked about the spinal trigeminal nucleus, pain and temperature for the face. And so that was part of lateral medullary syndrome and does continue up into the pons. But once we get into the pons, we see other parts of the trigeminal system. For example, here's the trigeminal motor nucleus. Okay, we talked about how the chewing muscles and temporalis here, that there is a motor function of the trigeminal nerve as well. And there's another part of the trigeminal system. This is kind of way up here at the kind of pons midbrain junction, but we're going to cover this as well since it's part of the trigeminal system. And this is the mesencephalic nucleus. All right, so starting here at the junction between the medulla and the pons, we're still going to look for our midline pathways. From last time, the corticospinal tract, the medial lemniscus, the tectospinal tract, and now we're above the level where the hypoglossal nucleus was last time. But recall these are our kind of classic midline pathways here in the brainstem. We last time talked about the dog ears of the medulla, and here's a nice cartoon drawing of a dog. And remember, that is the inferior cerebellar peduncle. So we talked about the involvement of that last time in lateral medullary syndrome. And also in our last lecture, we pointed out the salt and pepper appearance here, that the black part of this is the lateral vestibulospinal tract, which I mentioned because it's an important anatomically part of that decerebrate posturing. So here in the lateral medulla and also in the lateral portion of the lower pons, we have all of these vestibular and cochlear nuclei. So all important components of the inner ear, the vestibular apparatus, hearing, all is in this location. And there are a bunch of individual nuclei here, and I don't think it's important that you know that. It is important that you're able to identify cranial nerves on all of these sections. And so what we can see out here, now notice we're in the lower pons. Okay, what is around here, if you just want to label this, this is the cerebellum. The cerebellum is all around this. Okay, remember the cerebellum lies between the medulla and the pons, and the fourth ventricle with choroid plexus is in between. So what are these two nerves coming out here? Well, where are we? We are at the pontomedullary junction, or otherwise called the cerebello-pontine angle. Here's the cerebellum, here's the pons. And so what two cranial nerves come out right there? It's cranial nerves 7 and 8. All right? And so this is a lower motor neuron because it's a nerve that is going directly to muscles. Okay, and so this is the nerve that is involved in Bell's palsy, or remember that tumor that can grow here, an acoustic schwannoma, which early on tends to compress the 8th nerve, causing hearing loss, vertigo, tinnitus, and then as the lesion, the tumor grows, it may compress on the 7th nerve and cause facial weakness, and it can even compress the cerebellum and give ataxia, and sometimes even can compress rarely on the pons itself. All right, so let's say just a bit more here about the facial nerve. We went over this in our neuroexam lectures, but I'm just going to emphasize again because it's so important that you need to know the difference between a lower motor neuron facial weakness, where we have a lesion of the nerve itself or of the nuclei. Okay, either one of those, it's lower motor neuron, and it's going to produce weakness on the entire side of the face. Okay, this is what we see in a Bell's palsy. versus a lesion of the cortical bulbar tract. Remember, the cortical bulbar tract is going from the cortex to talk to brainstem motor neurons that are involved in moving your face, talking, swallowing. In this case, we can see the innervation of the upper and lower face nuclei for the facial nerve. Okay, and recall that we have a dual innervation of that part of the facial nerve to the upper face. And that's why when someone has a stroke that involves the cortical bulbar tract, they're just going to have lower facial weakness. If it's Bell's palsy, it's going to be the entire side of the face. This is not a gross anatomy course, and so I'm going to let the anatomists go over in more detail the facial nerve. I still remember as a medical student the different branches, which you can remember by the mnemonic to Zanzibar by motor car, but I won't ask you about that. I will just highlight a couple of things here. One is that taste sensation. Last time we talked about how the nucleus solitarius processes taste from 7 and 9, and here we can follow this. And if you just want to label it, here's the nucleus solitarius for taste. Okay, but our emphasis now is on the motor nucleus of the facial nerve. So by far the most common cause of facial paralysis is Bell's palsy, which is reactivation of the herpes simplex virus. Typically, the initial symptom is pain around or behind the ear, followed pretty rapidly by lower facial weakness. So if patients are talking, they'll notice their speech is funny. If they're eating, liquids are going to spill out of that side of the mouth. And that tends to get noticeably worse over a few hours, usually bringing them to the emergency room. Recall that the facial nerve supplies the stapedius muscle, which is important for dampening sound. So they're usually going to notice that sounds are a little louder in that ear. Okay, and because there is a taste and also lacrimation, in fact here we can see the lacrimal gland here supplied by the facial nerve, and so there will be some decreased tearing and loss of taste. The decreased tearing is important also because remember the facial nerve closes the eye. So acutely, these patients can't close their eye and they have decreased tearing. So it's really important when we see someone with Bell's palsy, we want to give them drops, to keep the eye well lubricated. And typically we're going to ask the patients to tape the eye shut at nighttime because you don't want the eye to dry out and you get a corneal ulcer or something like that. So if you see someone with Bell's palsy within the first 3 days, we give them steroids, which are clinically proven to shorten the duration of the facial weakness and to have a better overall recovery. We don't have evidence that it's helpful if it's given after that. The use of acyclovir, which inhibits DNA synthesis and thus viral replication, we really don't have good evidence for using this, but you will see that it is frequently used despite a really good clinically controlled trial that showed benefit from steroids and not from acyclovir. Prognosis is generally very good for Bell's palsy. Now, a condition that looks a lot like Bell's palsy, but is a different etiology, is Ramsay-Hunt syndrome. And this is due to herpes zoster oticus, which kind of hangs out here in the geniculate ganglion. And these patients also present with typically ear pain and facial weakness. So you may think, okay, just another case of Bell's palsy, but the eighth nerve is involved also in Ramsay-Hunt syndrome. So these patients have usually hearing loss, ringing in the ear, which is tinnitus. And I'll just have you add to your handout, these patients can also have vertigo as well from involvement of the vestibular component of the eighth nerve. So whenever you see someone with Bell's palsy, it's very important to look in the ear. Because if you look in the ear and you see these vesicles here, now you know, okay, this is not Bell's palsy, we're dealing with Ramsay-Hunt syndrome. So here's a patient with Ramsay-Hunt syndrome. He comes in with right facial weakness. Notice he's able to close the left eye, but he can't close the right eye. Okay, and it's a little bit difficult without a video, to appreciate the weakness of this entire side of the face, but we look in the ear, we see vesicles. The patient has Ramsay-Hunt syndrome. All right. Notice also we have the sixth cranial nerve right here, the abducens nerve. When we did our gross brain labs, we commented on this, that this nerve comes out along the midline, right between the junction of the pons and the medulla. Notice also we have the basilar artery right here, which sits, very large artery, lies right on the pons. So last time we talked about how the anterior spinal artery supplies the midline of the medulla, the pica supplies the lateral medulla, and the basilar artery supplies the pons. There are these penetrating branches that you can't see here that supply the pons. So if we ever have a Pontine stroke syndrome and you're asked to identify a blood vessel, make sure that you choose basilar artery. And so this is a rule of thumb for every brainstem syndrome that we can talk about, including occlusion of the basilar artery. So first, we look for crossed findings. And so that involves ipsilateral cranial nerve deficits, okay, which we talked about with both medial and lateral medullary syndrome. But when the lesion's in the pons, because cranial nerve 6 and 7 are in the pons, we're going to look for a 6th and a 7th nerve palsy, and we'll look for contralateral motor or sensory deficits. So again, the importance of just knowing where cranial nerves are in the brainstem. Also, a lot of the reticular activating system is in the pons, and so a lesion there often will cause coma if we knock enough of the reticular activating system out. Okay? And then just recall our crossed findings in lateral medullary syndrome. Okay, we had an ipsilateral 5, 9, and 10, nucleus ambiguous, the facial sensation, and contralateral, remember the opposite arm and leg had decreased pain and temperature. And with medial medullary syndrome, remember we had an ipsilateral 12th, contralateral motor and sensory findings. Okay, but now in the pons, it's going to be an ipsilateral 6 and a 7th nerve palsy. And in our next lecture in the midbrain, we'll talk about how you get ipsilateral 3rd nerve palsy, typically, and contralateral weakness. Okay, whenever the lesion is above the brainstem, all of the deficits are generally going to be on the opposite side of the body. You don't get these crossed findings. All right, another unique thing here about facial sensation. In our neuroexam lecture, we talked about the 3 branches of the trigeminal nerve, V1, V2, and V3. So if someone has something, compressing one of these branches, we get a very distinct, discrete area of sensory loss. Okay, but that's not how things are wired in the brainstem. So here is the spinal trigeminal nucleus, and notice that here, the lower part, which is called the pars caudalis of the spinal trigeminal nucleus, this supplies this distribution. As we move up, we have this distribution, and then all the way up in the pons is called the pars oralis of the spinal trigeminal nucleus, because it gets this area around the mouth and also the nose. So this can be very important to realize. Here we have a girl that presented with facial numbness, okay, and here in the dark area of the pen is the area where she has decreased sensation to pain and temperature, but she has preserved sensation around the nose and mouth. So this cannot be something compressing V1, V2, or V3, right? We have this area preserved right here. So what does that tell us? Well, this is preserved, the spinal trigeminal nucleus in the pons, but the spinal trigeminal nucleus and tract in the medulla must be affected to give us this pattern of sensory loss. Okay, so if we see someone with, this is called an onion bulb pattern distribution of sensory loss, where it's kind of layered like this, then we need to do a brain scan of a patient like this. And we can find that this patient does have a lesion that lights up here in the medulla. And we knew the lesion would be in the medulla because these areas for pain and temperature are affected, and those are come from the medulla. Okay, and when we do a cross section of that, we can see like a cross section like this, we can see the lesion right here. All right, so on the previous slide I didn't point out, but we can still see the inferior olivary nucleus, so we'll talk more about that in the lecture on the cerebellum. Okay, now as we move up a little higher to the level of the deep cerebellar nuclei, and I realize this can be a little bit frustrating because our lecture on the cerebellum is later, but I'm still going to point out some of these areas of cerebellar anatomy, even though the real function and description of that will come up later. But let's go back to our more familiar, what are the midline pathways here in the pons? And we still find our familiar corticospinal tract, medial lemniscus, tectospinal tract. Okay, just like we saw in the medial medullary syndrome, we can still follow those. But now when we move up into the pons, remember what connects the pons with the cerebellum? It's the middle cerebellar peduncle. Okay, so now we're above the level of the inferior cerebellar peduncle. Okay, and the middle cerebellar peduncle is by far the largest cerebellar peduncle. Okay, and there's a pathway that in our lecture in the cerebellum we'll talk about in detail called the corticopontocerebellar tract. And it is how the brain communicates with the cerebellum. And so that's the only pathway that travels through the middle cerebellar peduncle. So if you want to draw an arrow going this way, okay, this is entirely a pathway that is going into the cerebellum so that the cerebellum can serve as its role as a comparator. Now there's another pathway here. First I'll just point out the inferior olivary nucleus. This cut is a little not perfectly straight because we should see it on the other side, but notice there's a big pathway coming out of the inferior olivary nucleus. And we can see it here, and we can also see it over here. And this pathway is called the central tegmental tract. And the central tegmental tract connects the inferior olivary nucleus with the red nucleus, which is a nucleus we will see in the midbrain. And the only reason that I pointed out is because a lesion of the central tegmental tract results in something very curious known as palatal myoclonus. And these are patients that notice that their palate is rhythmically just going up and down continuously. It's very annoying. It persists during sleep. Patients perceive that as like a clicking sound. And when you have them open their mouth, you look at their palate, you can just see it going up and down, up and down, up and down. So if you see that, you need to get a brain scan. And we want to look at the pons because something is going on. If you disconnect the red nucleus from the inferior olivary nucleus, you get palatal myoclonus. And I was at an anatomy conference years ago, and someone asked, how does that work? What does this have to do with the palate? And the anatomist tried to be funny and said, the reason is ambiguous. And he meant ambiguous, the nucleus ambiguous. Apparently there's some connection between the inferior olive and the nucleus ambiguous. And since the nucleus ambiguous is motor for 9 and 10, somehow a lesion here results in dysfunction, improper neural input to the nucleus ambiguous, and that palate just continues up and down. Okay, so the whole cerebellum is back here. This is all the cerebellum. Okay, so again, in between the brainstem, the medulla and the pons, and the cerebellum, we have the fourth ventricle. And so here we have some choroid plexus. Okay, and these are called the deep cerebellar nuclei. And very soon we will talk about the function of these. For now, I just want you to get the names. The largest one here is the dentate nucleus. And then we have the emboliform, and the globose, and the fastigial. Okay, so if you want to remember dogs eat good food is a way to remember the lateral to medial representation of those. We can also see the large nodulus of the cerebellum. Remember the flocculonodular lobe is very important for eye movements, controlling regulated eye movements. So if we have a lesion here, the patient's going to have nystagmus probably and vertigo. Okay. And we still have these vestibular nuclei out about in this location, just like what we talked about in lateral medullary syndrome. Now this kind of puff of smoke going all through the pons is the reticular activating system. So recall that these are millions of neurons here that are like the light switch that lights up your brain, the light bulb. And so that's why I said if we have a lesion that is large enough here in the pons and you knock out enough of the reticular activating system, then the patient will be unresponsive and in a coma. Okay, a cartoon representation of the things we've talked about. All right, now as we move up here, this is, I think, the most important section because the most commonly asked clinical syndrome and kind of the payoff for this lecture is that you can recognize a lesion in the pons because the cranial nerves that are most prominent here in the pons are 6 and 7. So here's cranial nerve 6, here's cranial nerve 7. So I mentioned that the 7th cranial nerve, it doesn't just exit out into the cerebellar pontine angle. For some reason, it loops all the way around. This is the bend of the facial nerve, so we call it the genu of the facial nerve. It wraps all the way around 6 on its way out. Here we saw it before in the cerebellopontine angle. Now, if you go back a couple slides, where did we see cranial nerve 6? It exits right here in the midline. What does that mean? Well, if you see a patient with a 6th and a 7th nerve palsy, the lesion has to be in the pons because these cranial nerves lie like miles apart. Here's 6, here's 7, as they exit the pons. They're very close together in the pons. Okay, so this is very important. Remember that we call the 6th nerve the PPRF 6 nerve complex. So here's the 6th nerve, and here we can see it over here, but really the PPRF is also going to be a part of that. Okay, and what is a pathway that comes out of the 6th nerve PPRS complex? It's the medial longitudinal fasciculus. It's medial, and remember this is going from the PPRF 6th nerve complex up to the midbrain to talk to the 3rd nerve nucleus so that our eyes track together. Specifically, it talks to the medial rectus, the part of the 3rd nerve that controls the medial rectus. Okay, so our midline pathways again, cortical spinal tract, medial lemniscus, tectospinal tract, and now we're adding a 4th midline pathway, which is the medial longitudinal fasciculus. Okay, here we can still see the central tegmental tract. So this sort of forms an L here with the medial lemniscus and the central tegmental tract. Okay, and of course we're still seeing the 4th ventricle out here. So let's say a bit more about this important relationship. And I forgot to mention also the middle cerebellar peduncle. Oh, and before we do that, I just wanted to point out one other thing. This is so small, I would never ask you to identify this on a section, but here is the superior olivary nucleus, which has just to do with sound processing. So I'd just like you to know the function of the superior olivary nucleus. So it turns out when sound comes in, these auditory pathways, as they're traveling up to the thalamus, cross back and forth many times. And sound reaches the right and left superior olivary nuclei. There's one here and one about over here at slightly different times. And so the function of the superior olivary nucleus is to help you localize sound. And we're actually pretty good at this. If you've ever been to a party or something like that, you're talking with someone, but something really interests you that is happening on the other end of the room, and we're actually pretty good at allowing, to focus our hearing to hear in a different location. So that ability is a function of the superior olivary nucleus. So I just want you to associate that with auditory processing. So here is our important syndrome in the pons. Okay, and so here is cranial nerve 7 wrapping around cranial nerve 6, and here I've drawn in the cortical spinal tract. So if we have a stroke in the pons, like a basilar artery occlusion that affects, in this case, the left side of the pons, then we're going to have a left 6th and a 7th nerve palsy. So notice this patient has a left 6th and a 7th nerve palsy. There's Notice no wrinkling of the frontalis muscle. We have some facial droop here. Okay, that's the 7th nerve involvement. But the 6th nerve involvement means this eye can't go out, so it gets pulled in. So we have a left 6th nerve palsy. Okay, but if we affect the corticospinal tract here, on the left, this hasn't crossed over yet, and so that is going to cause right-sided weakness. Okay, so this fulfills our criteria for any brainstem syndrome, which is ipsilateral cranial nerve deficits, in this case 6 and 7, contralateral motor and or sensory deficits. Now, could you have other things involved? Yes, you could have sensory loss on the opposite side, but these are the core features of a Pontine lesion. I don't care that you know the name, Millard-Kubler syndrome. My son tried to remember this by naming his cats, one of them Millard and another Gubler, and we have a dog who he calls Cindy. Anyway, the Millard-Gubler syndrome. So I don't care that you know the name, but you do need to be able to localize that. And why is it important to localize that accurately? It's going to totally depend on what type of neuroimaging we do. If we do a CT, we're not going to visualize this. Okay, if you think the lesion's in the pons, we need an MRI scan to be able to pick this up, typically. Okay, so again, here is 7, here is 6, and so this, you can't really see the fibers go this way, but here they are wrapping around. So all of this is 7th nerve wrapping around the abducens. Okay, and this very midline pathway right here is the medial longitudinal fasciculus. Okay, and just a cartoon drawing of this. All right, so from this drawing, which I recognize is a bit intimidating, there are just a few things that I want to go over, and actually a lot of this we've done already, so this will be for review. One is about the vestibular ocular reflex. Recall that when you're moving your head back and forth, that causes a change in flow of endolymph in the semicircular canals. Okay, so this is going to go in via the 8th nerve to a vestibular nuclei. I don't care that you know which one. Okay, but this crosses over to the opposite PPRF 6 nerve complex. So in this case, let's say you're turning your head to the left. Notice the eyes here are going to the right. How does that work? You turn your head to the left. That ends up stimulating the right PPRF 6 nerve complex. Okay, if we stimulate the 6th nerve, that's going to activate the lateral rectus, so the right eye moves to the right. Okay, we need to get the left eye to cooperate. So to activate the medial rectus here, we need this important pathway from the PPRF 6 nerve complex, which is the medial longitudinal fasciculus, right here. Medial longitudinal fasciculus goes up to this is all the 3rd nerve nucleus here, but there's a nucleus within the 3rd nerve nuclear complex that supplies the medial rectus. Okay, so here's the 3rd nerve going out to the medial rectus, and now the left eye also moves to the right. Okay, so moving your head to the left causes both eyes to go to the right simply by activating the opposite PPRF 6 nerve complex. So that's our vestibular ocular reflex that we've talked about already. The other thing that we've talked about already is if we have a lesion of the medial longitudinal fasciculus, which is we can see here in the dashed line. Over here it's a solid line. Okay? So recall that if we have an MLF lesion, that deprives the stimulation of the medial rectus nucleus here in the 3rd nerve complex, and so we're only allowed to have one muscle that is weak, and that is the medial rectus. So if we have an MLF lesion here on the left side, then when the patient tries to look to the right, this right eye can't look very well towards the nose. And recall, we get a little nystagmus here in the right eye to try to bring the images together. So we call this MLF lesion an internuclear ophthalmoplegia because the lesion is between nuclei. It's between PPRF6 and between the 3rd nerve nuclei. And just recall that that is classic for multiple sclerosis. If you ever see someone with an intranuclear ophthalmoplegia, make sure to ask them to look to their nose, because there is a convergence nucleus right here that activates both medial rectus nuclei independent of the medial longitudinal fasciculus. So that's why looking to the nose is preserved in patients with an MLF lesion, even though when you're asking them to follow your finger or your pen, that one eye cannot look to the nose. Okay, the other thing that we talked about in the neuroexam lecture, so this is review, is if we have a lesion out here that destroys the 6-nerve PPRF complex, and so this gives us a horizontal gaze palsy. So if we have a lesion on the right, recall that the right PPRF 6-nerve complex wants to drive the eyes to the right. 6th nerve wants to move your right eye to the right, and then that MLF pathway over here wants to drive the left eye to the right. So if we have a lesion here, the eyes can't look to the right. They have a horizontal gaze palsy, and sometimes, if it's severe, the eyes will get driven completely in the opposite direction. Okay, and then in the neuroexam lecture I mentioned you can have the, you involve the descending corticospinal tract, and then patients will have a contralateral hemiplegia. All right, now this is new information, and at least I get emails about this every year, and so I want to include something that we often see, which is if we have a lesion right here, but it's just a little bit bigger, it's not hard to imagine that this can also extend to involve the medial longitudinal fasciculus. Okay, so our lesion is right here. So these patients will also have, like we said, a horizontal gaze palsy. If the lesion's on the right, they can't look to the right. But now they're losing the medial longitudinal fasciculus, which is how this right eye, the innervation to the medial rectus in the right eye. So these patients can't look to the right, and when they try to look to the left, this eye just gets stuck. So this eye doesn't look to the right, and it also can't look to the left. So the classic thing in this lesion here, which we call a 1.5 syndrome, is that when the patient's looking from side to side, basically neither eye moves except for the 6th nerve supplying the lateral rectus here. This nerve is not shown, it's shown over here. That's the only thing that works. Okay, so if we have a large lesion here, the patient cannot look to the right at all, and when they try to look to the left, this eye is able to look to the left, this eye does nothing. So that's called a 1.5 syndrome, and again, that could be multiple sclerosis, it could be a stroke, there are a number of different things, but we're going to need to get a brain scan because something is going on there. And I'm recording this lecture now for the second time because I tried to show a video of a 1.5 syndrome and it somehow caused the video to lock up. So I'm just going to show that in class. Okay, so here are patients with multiple sclerosis who have a lesion of the MLF, and we can just see it's really small. A little bright spot right there. Okay, so again, they're going to complain of double vision. Now, since we're talking about the 6th nerve, it's important that you realize that when we have increased intracranial pressure, the nerve that is most likely involved in that is the 6th nerve, and it's frequently a bilateral 6th nerve palsy. The 6th nerve has a really long course, and so when you increase pressure in the brain, that pressure gets exerted down and it tends to stretch the 6th nerve. And so again, increased intracranial pressure is a neurologic emergency. These patients may also have a Cushing's reflex that we talked about last time. They may be confused. They'll probably have papilledema when you look in the eye and have headaches. So this is what a bilateral 6th nerve palsy looks like. Now this patient is looking straight ahead, and you can see the eyes aren't conjugate. This eye seems to be pulled in a little bit. Okay, when we ask her to look to the right, this eye seems to look pretty good to the right. This eye isn't able to abduct normally. Okay, but also when we have her look now up and to the left, this eye is, seems to be looking okay, but this eye is not able to abduct normally. When we have the patient look down and to the left, this eye moves in pretty well, but this eye is not abducting normally. So neither eye abducts normally. And that's diagnostic of a bilateral sixth-nerve palsy. And when we see that, again, generally, it's a neurologic emergency. We need to do a brain scan and figure out, what's going on. Another brainstem syndrome is called locked-in syndrome. And this is where we have a stroke or a hemorrhage that involves the pons. And remember, sometimes with the pons, patients will be in a coma. A locked-in syndrome is where we have a pons lesion, but you spare enough of the reticular activating system that the patient is still awake. And these are devastating strokes because, with a large stroke with the pons, you knock out all of the descending cortical spinal tract, the cortical bulbar tract. So generally, these patients can't move their arms and legs. They can't talk. They can't look from side to side because this is knocking out PPRF6 and all of that. But the one thing they can do pretty well is to look up and down. Okay, why is that? Because the midbrain is what's important for vertical eye movements. So these patients can blink, they can look up and down. First patient I saw with this was when I was a neurology resident, and I was called to evaluate a patient to see if she was brain dead. And she couldn't move. She didn't respond to any commands at all. And I remember lifting up her eyelids, and there just seemed to be some fear there in the facial expression. And so I asked her if she could close her eyes, and she did. And then I said, "Can you close your eyes 2 times?" And she did. And then I said, "Can you look up at the ceiling?" And she was able to. All right, so when a patient can only look up and down and blink, then the lesion is in the pons, and this is part of locked-in syndrome. So a horrible, one of the worst things that we see in neurology, very sad, and typically these patients don't survive very long. Now, as we get above cranial nerves 6 and 7, we get to other components of the trigeminal system. First, let's talk about pathways. So we still have the cortical spinal tract right here. And tectospinal tract's pretty small, but we can see the medial longitudinal fasciculus. Here's the medial lemniscus and the central tegmental tract. Remember that L formation there? Okay, again, here's the fourth ventricle. Okay, but the main thing we want to point out here is the other components of the trigeminal system. So the trigeminal motor nucleus is very large. It's right here. We can see it over here. And the nerve fibers that project from that, you can see it's almost like a hand going into the nucleus. Here we can see it over here. And so these then are the trigeminal motor fibers that go out to supply the muscles of mastication, the temporalis, the pterygoids, the masseter. All right, and so if we have a lesion right here in the pons, then the patient will have weakness with chewing. We'll see atrophy of those muscles. And since the pterygoid tends to pull the mandible forward and towards the midline, just like the hypoglossal, each half of the tongue tends to project the tongue towards the midline. If we have a lesion here, the chin deviates in the direction of the paralyzed side when the patient's asked to open their mouth. So if you have jaw deviation, then we'd want to think about a lesion of the trigeminal motor nerve or the nucleus. Now the other components here, it doesn't show up that well, but there's a nucleus right here. Right here. And this is the principal, or sometimes called the chief, spinal or trigeminal nucleus. Okay. And this is important mainly for vibration and light touch sensation. Remember that the spinal trigeminal nucleus is pain and temperature. And so the principal sensory trigeminal nucleus is for vibration and light touch. And also when we talked about the corneal reflex, you touch the cornea and both eyes close. This is the nucleus that mediates that because it supplies the cornea. Okay, so if we have a disruption to the corneal reflex, it could be a lesion here involving this area of the pons. Now, the mesencephalic trigeminal nucleus is up here, okay, and this is really a displaced sensory ganglion, and this is important for proprioceptive information. So when we talk or chew, it's pretty important to know where your jaw is in space. And so when you move your jaw, you're stretching muscle spindles, and that information is detected here in the mesencephalic trigeminal nucleus, which then can communicate with the immediately adjacent motor trigeminal nucleus, so that we're very precise with chewing and talking. Okay, so we mentioned the corneal reflex is mediated by the principal sensory trigeminal nucleus. The jaw jerk reflex is mediated by the mesencephalic trigeminal nucleus, and I have a picture here to show you what that looks like. Okay, so we already talked about the jaw deviation and weakness that you can get with a lesion of the motor trigeminal nucleus. Okay, here is the mesencephalic trigeminal nucleus, and so let's say you are talking or chewing. With every jaw movement that goes up to the mesencephalic nucleus, which then can communicate with the motor trigeminal nucleus, which is right here, to regulate, very precise chewing and talking. And also when we do the jaw jerk reflex, where we tap on the jaw and it snaps back up, you're stretching muscle spindles, just like when you do reflexes in the arms and legs. So it's a loop that goes up to the mesencephalic and then to the trigeminal motor nucleus, so that the jaw snaps back up. Okay, so when would we check the jaw jerk reflex? Well, if we have any upper motor neuron lesion, any lesion that is really above the pons and midbrain, you can have an abnormally brisk jaw jerk reflex. So that can be an upper motor neuron finding. All right, and here is just a drawing we talked about earlier of the corneal reflex. Okay, but when you touch the cornea, here it is the chief or primary or principal trigeminal sensory nucleus here that activates both facial nerve nuclei. So again, you touch the cornea, here's the chief sensory trigeminal nucleus activating both facial nuclei so that both eyes close. Okay, and then just recall, so it's important for the corneal, but it also mediates vibration and light touch sensation. Okay, so just to kind of go over a little bit about auditory pathways. Of course, we have the cochlea and the eighth nerve, and I pointed out where the cochlear nuclei are, sort of in the lateral medulla, lateral pons, and said you don't need to know the individual ones. Here, I just wanted to remind you that as that auditory information is ascending, remember that it hits the superior olivary nucleus at slightly different times, which is what allows us to localize sound. Okay, and now we're going to follow auditory information as it travels up through a pathway called the lateral lemniscus. So don't get that confused with the medial lemniscus. Medial lemniscus is for vibration proprioception. The lateral lemniscus is important for ascending auditory information. Okay, this goes to the inferior colliculus, and then from there to the medial geniculate for sound, and then finally up to Heschel's gyrus in the brain. One other important thing about this is that ascending auditory information crosses back and forth many times. And the importance of that clinically is that when we have lesions in the pons or the medulla, patients almost never have hearing loss, okay, because the information is crossing back and forth, back and forth. So generally, if someone has lost hearing in one ear, the lesion is going to be out in the inner ear, the cochlea, or we've got compression of the eighth nerve like an acoustic schwannoma, not a lesion here in the brainstem. Okay, and then finally, we're now sort of just below the midbrain, and we can still see the corticospinal tract here. Here's the medial lemniscus, and notice this whole time I have not been pointing out the spinothalamic tract, but now it's large enough that we can label it again. It's been there the whole time, but just kind of hard to identify. So notice that as we move up through the brainstem, the medial lemniscus eventually sort of travels together with the spinothalamic tract. So again, this is vibration proprioception, pain and temperature, and all of this is headed up to the VPL of the thalamus, going to the same thalamic nucleus, all sensation for the arms and legs. Opposite side. Okay, now here is the lateral lemniscus. Okay, so this is auditory information going on its way up to the inferior colliculus. I should have pointed out earlier, but in the pons, we see all of these bright areas. This is all nuclei. So these are Pontine nuclei, and we'll talk about this in our lecture on the cerebellum, because this is really a relay nucleus for cerebellar information. Okay, but notice I tried to draw here a pathways going into the Pontine nuclei, and this is the corticopontocerebellar tract. Okay, so again, this is something that we will map out in the cerebellar lecture, but this is how the brain tells the cerebellum about the intended movement. Okay, it goes down via the corticopontocerebellar tract, synapses on Pontine nuclei, and then crosses over into the cerebellum. So we'll explain that later on. We can still see some of the reticular activating system here. Here is the medial longitudinal fasciculus. And now we're beginning to see a little bit of the superior cerebellar peduncle, but that's going to show up a lot better here in our next lecture in the midbrain. So I would like to point out what's in the dorsum of the pons here. Notice we have the cerebral aqueduct, and around that the periaqueductal gray. In our lecture on pain, we'll talk about the importance of the periaqueductal gray for pain modulation. This area is loaded with opioid receptors, okay, and so we'll talk about its role in pain control and regulation. And notice also we have a nerve exiting back here, and this is the only nerve that exits the dorsum of the brainstem. This is the trochlear nerve. So recall, these are patients that are going to tilt their head in the opposite direction so that they don't have double vision, and they're going to have difficulty reading, walking downstairs, because that down and in will bring out double vision.